Hey everybody, it's Dr. Eric Balcavage, and I'm joined by Dr. Kelly Halderman, my co-author in the book, The Thyroid Debacle. And this is the Thyroid Debacle Q&A. This is the, I don't know, third or fourth one we've done. And so today we've got, as usual, a bunch of questions that we're going to answer. And if you're attending and you've got a question, you can go into the chat and put it in there. And we'll try and get through as many of these questions as we can. Just a heads up, the Thyroid Debacle book is out. It's on Amazon, Barnes & Noble. It is on Balboa Press's site too, but Amazon and Barnes & Noble it's definitely out on. I know a bunch of people have asked, is it on the UK? Is it on international Amazon? And the answer to that is yes, it is available on those sites. One of the things that's really important is when you put in the Thyroid Debacle, we had it originally, we were with a different publisher. The cover was different. And so it's a white cover with like a little maze on it. And I think people are pulling that up when they're typing in the Thyroid Debacle. And it is, and that's the cover that's showing up. And people are saying, hey, it's not available. It's not available. It is available. Make sure you have this beautiful bluish, purplish, I don't even know what color that is, cover, because that's the one, that's the book that's out. It would have been the same book, just a different publisher. We can't for some reason get that removed. So that's the book you're looking for. If you buy the book, please buy the book. Go and do reviews. I was not aware of how important reviews are, but they're really, really important. So give us an honest review once you've read the book. Let us know what you think. Take a couple minutes. We really appreciate it if you'd be more than willing to give us a review. So we're going to get through some questions. We got some people lining up here. Remember, if you're joining the Q&A and you have some questions, just let us know. Type in your question and we'll try and get it answered. So Kelly, we've got question one. You ready?
I am.
All right. I should say, I'm Dr. Eric Balcavage. I'm a functional medicine practitioner. Started as a doctor of chiropractic, lecture, private practice. Mostly what I deal with is people with chronic health conditions, and I talk through the lens of thyroid physiology and the cell danger response quite a bit. Dr. Kelly Halderman is a dear friend of mine. We met a number of years ago, both at conferences together. We both speak quite a bit. But Kelly, why don't you introduce yourself? Because some people may or may not have heard of you. Who knows? But Why don't you give people a little bit of background on who you are and what you're doing currently, and then we'll get into the Q&A.
Sure. So thanks, Dr. Eric. So yeah, I'm Kelly Halderman. I was in another lifetime, I was a family practice medicine doc. I don't practice medicine anymore. I am focused on research and education. So take that with a grain of salt, that all the information in this webinar, go talk to your doctor about this information. We're not here to answer specific medical questions for you, but we are here to provide scientific data and things that can be used to take to your doctor. Dr. Eric sees patients, so you can actually come to him and get a free 15-minute discovery call to see if you're a good fit. But again, it's just for educational purposes, and that's really my forte. I work as a chief health officer now in corporate world, so I made the shift over there. So again, I do have a lot of experience. I do have, the medical training, and that's what I brought to this book. I brought all the education that I had, so that when you read this book, you understand why your doctor treats you the way that they do, because that's the allopathic model, and I was trained in that. Then Dr. Eric in part 2 goes into all the new model, which is just mind-blowing. And then part 3, we collaborate together because I also have a doctorate in clinical nutrition, very well versed in health coaching. I've really dug my own self out of a very, very deep hole of medical problems. And so, I've got to use my own life to help. And Dr. Eric helped me too. So let's answer that first question, Dr. Eric.
Sure. So the first one is, can you speak to low-dose naltrexone and the research on it for lowering inflammation for thyroid patients? What do you think?
Sure. So my resource that I point people to when they talk about LDN is the LDN healthcenter.com. I had to get that right. It's a long one, but the ldnhealthcenter.com is the best place to go for, now here's my little brochure, for providers, for lay people to learn about the research that supports this drug, which is called low dose naltrexone. Low dose naltrexone has been around for a really long time. And it just so happens that, in the past, maybe 20 years, we started doing research and looking at what else can it help with for the other things that it was used for traditionally. And lo and behold, if you go to that website, I just actually went there to prep for this webinar, and they do have some information on studies that have been done in people with Hashimoto's, with autoimmune diseases. And, just full disclosure, I have Hashimoto's, and I was put on LDN by a dear friend practitioner a number of years ago. And it really made quite a difference for me. Now, I have seen people go on LDN and it do nothing. And so, the LDN Health Center, you can find a provider, you can learn more information. If you're a pharmacist, you can learn more information. It is a one-stop shop for all things LDN. And I recommend that anyone wanting to learn more about it, go there.
Yeah. And so I don't prescribe, so it's not something I use in my practice, but I think, kind of building off of what you said, I think for some people, because of the really like an anti-inflammatory type effect, it's going to be really beneficial, right? And so for some people, when we talk about the cell danger response, and we can be stuck in a cell danger response, the thing that triggered it could be gone, but we're still stuck in this adapted state. And I think it's probably really helpful for those people to kind of calm that immune inflammatory cascade. We talk about there's a lot of things that can help kind of boost the T regulatory system, right? That part of the immune system that kind of controls the immune response. But for some people who still have those things that are triggering an inflammatory response, maybe it helps a little bit, but it may not necessarily. So right. I think if it's something that you're going to consider, definitely reach out to somebody who's able to prescribe it, and somebody who's got a good resource on it. Kelly just gave you a good resource to check it out and educate yourself. All right, second question, ready? Second question is, can one have Raynaud's and hyperthyroidism at the same time? Thoughts?
I believe one can absolutely have those concurrently. I have seen that. How about you, Dr. Eric?
Absolutely. Listen, it's immune inflammatory process going on for the most part in both of these situations. So you can have any number of immune inflammatory conditions going on at the same time. We often look at the hyperthyroidism as the problem, or we look at the Raynaud's as the problem. That's the outcome, right? So something's triggering the immune inflammatory process to be upregulated. And so it's not unusual for a person to have not just one immune or autoimmune condition, but multiple immune or autoimmune conditions. And it's one of the reasons that I think we learned early on from Dr. Karazian when he was kind of leading kind of some of this thyroid discussion, maybe a decade or two ago, right? And saying, hey, if somebody's got he was talking back then about thyroid antibodies. If the reason it's important, most of these people have autoimmune driven thyroid disorder, and the real importance of knowing that they have thyroid, a thyroiditis, an immune driven disorder, is because if you don't address what's causing that immune driven disorder to begin with, and they have one autoimmune condition, there's a really high likelihood of them developing a second or a third or a fourth immune or autoimmune disorder. And I'm one of them, right? I had Raynaud's pretty bad for a while, and I had Hashimoto's, and both of those things are really good. But the problem is that you have to dig in and try and uncover and address some of those root cause issues to calm the immune system down. So treating the autoimmune disorder is okay, but ultimately you got to find out why it's going on to begin with, right?
Exactly.
All right, question 3. When there's so many systems out of balance, where do you start? So I'll give you the context for this because I know what the person was saying. I saw the comment like, hey, if I got thyroid issues and I've got gut issues and I got adrenal issues and I got hormone issues and I've got all these things going on, where am I supposed to start? Right. And I get it. It's frustrating, right? Like you go to because the person saying, hey, this person says you got to start with your adrenal system. This person's saying you start with your gut. This person's saying you start with your thyroid, and you got to balance the adrenal gland or the adrenal gland first. You got to balance the thyroid first. Where do you kind of put the start point at?
Well, first of all, we feel your pain, right? I mean, we were once, very weighted down with allostatic loads, and our bodies were definitely in that cell danger response. And so I think the best place to start, this is maybe not the answer you want to hear, but it's personalized. It's really what is weighing you down the most. Maybe your diet is garbage and your gut is really impacted. Everyone has their weakest link. But right, there are some high level things that we should be correcting the low hanging fruit first. We should be addressing the things that make the most impact. I will say I've been digging into the microbiome quite extensively lately in PubMed, going down rabbit holes. And what I've learned is that the microbiome has about 100 trillion cells. We're about 30 trillion cells. It has more gene expression than all of us that is human. There's more DNA running around from our microbes, and they're responsible for everything from vitamin production, butyrate production, all kinds of things. And so I feel like that's a very low hanging fruit, is to really optimize your gut function, get that working, and then when you optimize your gut function, lo and behold, your detoxification system, your moving your bowels and such, it'll work better. Everything will work better in that area of our body, the GI system. Again, we have to have that optimized in order for inflammation to be cut off. LPS, lipopolysaccharide from those endotoxins in the gut, that if you don't correct that, you're going to be chasing your tail. And so I really do feel confidently, like if you are totally stuck, you've been to a million practitioners, or you're going to a practitioner and you want to focus on something, if you leave out the gut, and if you don't treat that or take that seriously, all the other higher level things are not going to be corrected. So that's kind of my approach. What do you think, Dr. Eric?
Yeah, I'm a big believer that everything starts and ends with gut function and physiology. Everything's got to go in through the GI tract. Everything's got to come out through the GI tract. So it's really important to address. So, but I understand what the person's saying. Hey, there's so much stuff to do. Where do you start? Well, I agree. You start with the low-hanging fruit, and especially the things that really don't cost you to do, right? So start with real simple things. And actually, in part 3 of the book, we talk about them. Improve your diet. What diet, right? What diet am I supposed to eat? Am I supposed to eat AIP? Am I supposed to do low FODMAP? Should I do ketogenic? Listen, before you worry about all those, just eat more whole food, real food, right? Get rid of the processed food, eat more whole food and real food. That's a great place to start. Doesn't cost you anything, it really won't cost you more. It might actually cost you less. Get all the processed food out, clean up your diet. I think it's a great place to start because it's going to start helping the gut. And then look at the other lifestyle factors we talked about. Look at your sleep, look at your respiration. Like, what are the things that you're doing poorly as far as your sleep fitness, your respiratory fitness, your emotional fitness on a daily basis that you can manage, right? Start with what you have control of. Even when we talk about in the environmental toxicity and environmental fitness chapter, oh my gosh, there's toxicity everywhere. Right. Before you jump to toxicity testing, how about just start with the things that you have great control over? Hey, I'm going to reduce the toxic things I use every day in my diet, my life. Let's start simple, right? Start with deodorants and personal products. Get a cleaner version of those things, right? Cleaning products. Don't use that stuff that's so potent with toxic chemicals. Use something that's a little cleaner, better for you, better for your environment, better for the environment in general. Just start slowly cleaning those things up. When it comes to the systems specifically, I'm a big proponent of the gut as a good starting place. Some people say, well, you have to balance your thyroid hormone. Well, when I hear people say you have to balance your thyroid hormone, I'm not sure what that means, because we're talking about this in the book, like thyroid physiology adapts to the given stress on the system. And we talk about it in the book that cells either operate from a manufacturing mode or a cell defense mode. So if the cells are in a cell defense mode, you can pump T4, T3 into the system. You may make the blood work look pretty, but people don't necessarily feel well for an extended period of time. So you're not going to necessarily balance it. If the thought process is that your thyroid gland just woke up one day and decided, hey, I'm not going to work, or your immune system woke up one day and said, hey, we're just going to destroy the gland, and it was just as simple as putting more thyroid hormone into the system, everybody would feel great, because we're overloading people with thyroid hormone. It's crazy. Listen, I just did a discussion, a phone call with somebody, and they were taking T4 and T3 combination for years. They felt great initially, honeymoon period over, higher and higher doses of combo therapy. She started working with me. I'm like, let's get you back on T4 and let's see where we're at. Within she switched to T4, feels better, felt better with the start of that. We just got, 40 days of labs, or 40-day follow-up of her labs, and she's already hyper overdosed, right? So she went from couldn't feel good, now feeling better on T4 only, and she is overloaded. So in just a short period of time, she is absorbing thyroid hormone better, because what have we been working on for the last 30 days? Hey, we've been working on diet and gut function, right? Trying to clean up the bacterial imbalance, trying to help her heal her leaky barrier. And so the gut becomes so critically important, because if you're going to take medication, you can't put stuff in. So don't try to balance your adrenal gland, balance your thyroid gland, balance all the stuff. Start, my opinion, for most people, and this is not for necessarily everybody's situation, but when we look at your health history, your health timelines, your signs and symptoms, if there's an indication there's a gut issue, I would say I'm going to start right there, because if you're going to take medication, you've got to be able to absorb it, right? You got to be able to metabolize and detox that stuff. And the last phase of detoxification is your GI tract, right? Kelly and I talk about this when we talk about detoxification. Everybody talks about phase 1 and phase 2 liver detoxification, and they're important, but you also have to have what Kelly's coined 2.5, which is getting the toxins out of the liver into the bile flow, and then phase 3 is getting it in and out of the gut and the GI tract. So I think that's an important place to start, and then you just keep working your way through systems. Okay. And then what system is next really is, as Kelly said, really important or dependent on what are the primary issues here. Many times somebody will come in and I see it a lot with women, like, hey, my primary issue is I can't get pregnant, can't maintain a pregnancy. And I want to get pregnant. I'm like, you've already done hormone replacement therapy. You tried all this stuff. It's not working. Your issue isn't, about hormones. Your issue is you have an inflammatory issue. So where's the bulk of the immune system at? It's in the gut. Let's check your gut and let's address that first. And guess what happens many times when you're working on them? In the middle of working on them, they're like, I'm pregnant. Yeah, how about that? Because it's that the GI tract is that important. I think we beat that one up, right?
Yes, I totally think we did.
All right. So here's the next question. You ready? I'm confused to which thyroid medication is best. Some say T4 only. Some say T4, T3 combination. Some say T3 only. How is someone supposed to know which one to take? You want me to start?
You kind of started down the road there of the medication. Why don't you come back at that and answer it in that context?
So when we think about thyroid hormones, the two primary thyroid hormones that are discussed are T4 and T3. Most of the T4 in the body is made by the thyroid gland. Very little T3 is made by the thyroid gland. It's like 5 to 10 micrograms is typically made by the thyroid gland. Out of the total how much T3 can vary depending on the size of somebody and their metabolism and stuff. But let's just roughly say it's about 30 micrograms of T3 is made per day. And if 5 micrograms is made by the thyroid gland, that means the vast majority of thyroid hormone is made away from the thyroid gland. So most endocrinologists are going to tell you T4 only. It's the only thing you need. That's what the thyroid gland makes primarily. The thyroid gland is damaged. It is, you just give T4 to normalize TSH and the rest will figure itself out. And I have a tendency to agree that if we're going to provide somebody thyroid hormone, that probably initially, if we're working on their physiology and the root issues, I like to see people on T4 only. And here's why. Because if they take a bunch of T3, it can initially make them feel good because the body's not converting it well. But I want to see if their body is converting the T4 to T3, if those peripheral cells are converting T4 to T3. So I'm a big fan that in the beginning, when somebody's got a lot of health issues going on, a lot of inflammatory issues going on, we put as little T4 into the system as possible. And then we can use T3 and free T3 and reverse T3 as indicators of how good a job their body is doing converting T4 to T3 in the periphery. Okay. So I'd say I typically lean to a lot of people with T4 when if they're trying to address the root issues. If you've lost your thyroid gland, significantly destroyed, you're not putting a lot of time and effort and attention into addressing root issues, or you've addressed the root issues and you feel pretty good on T4 and a little bit of additional T3, about 5 micrograms or plus or minus seems to help. That's awesome. That's great. That may be the right thing. But what I think the problem I see with the medications is somebody goes and does T4 therapy. They have their honeymoon phase where they feel good. Then they take then their doctor gives them a stronger dose and they feel good. And then they say, all right, and then they plateau, and then they give them a stronger dose, and then they plateau. And now they're starting to feel hyperthyroid. So the doctor reduces the dose. And so they're up and down. Once they've hit that plateau, they never feel quite right. So they think that they're going to read a bunch of blogs, they're going to listen to a bunch of posts, go, oh, well, the thyroid gland also makes T3. So, and my T3 is low, I'll take T3 as well. And they initially feel good because now you're getting more T3. Your body's not converting the T4 to T3 very efficiently, and you feel good. But what I see is the same scenario. For some people who still have what we talk about, that excessive cell stress going on, the body didn't want to convert T4 to T3, so it wasn't. Now you're providing T3 initially, it helps, but then the body says, whoa, we don't want the T3, so we'll deactivate the T3. And so they wind up doing the same thing, increasing the dose, decreasing the dose, and still feeling not quite right, and wind up taking higher and higher doses of thyroid hormone. Eventually, they may read a blog, see a post, and somebody says, well, you should take only T3 only. And initially, when they take T3, they're going to take a bigger dose of T3. They feel pretty good. But I think the same thing happens because I've seen it. I got a bunch of those clients that they're taking high doses of T3 and they feel okay, but they still don't feel great. And the same thing happens. They start lower dose, go up, go up, go up. I've got a gal right now taking 80. I think she's taking, I didn't put her on the medication. Remember, I don't prescribe, but I think she's in the 40s with her T4 dose. And she's taking 80 micrograms of T3 per day, and she still feels hypothyroid. So I think which one is best is really going to be depending on you, who's prescribing it, and what the goals are. Okay. There are people that do T3 only and feel fantastic. That's great. It's a lot more work to take T3 only, and I'm concerned about what they're not getting when they're not taking sufficient thyroid hormone. And when I'm working with clients, my goal ultimately is to try and get them back to as close to normal function and normal physiology as possible. And the cool news is when you still have a thyroid gland, but it was just damaged, what I've seen in practice over 27 years is it's amazing that thyroid gland can start to recover, and people need lower and lower doses. But if you take so much thyroid hormone and suppress TSH too much, which often happens many times when you're taking the high dose combination specifically, there's no way that thyroid gland is ever going to start to function again. Your thoughts, Kel?
Yep, I second all of that. Spot on. Can't argue with the thyroid guru there. And everything you say is always backed up with multiple papers from PubMed and in your experience as well. So let me ask you question number 5.
Yes.
If you're ready to move on.
Sure.
Okay. Why might free T4 be elevated, but TSH and the rest of the thyroid panel are normal? Now, this is in the context of someone being on no thyroid medication. Patient is told they're fine, but has sleep issues, blood sugar regulation issues, chronic fatigue, et cetera, and they're recently diagnosed with thyroid nodules.
Yeah. So I don't know necessarily what normal is, right? What somebody's saying normal. And we talk about this in the book, that when we look at labs, context matters, right? So a lab value could be normal and appropriate. A lab value could be normal and inappropriate, right? A lab value could be, normal and appropriate, normal and inappropriate, abnormal and appropriate, abnormal and inappropriate. And so when we look at the labs, we want to look at the values and say, okay, what signs and symptoms does my client have? And let's look at the labs and see what's going on. But this is one reason why I and Dr. Kelly believe that you can't just look at a thyroid panel in the absence of everything else, right? Because it doesn't have enough context. Mm-hmm. So in this situation, we've got a person, and we don't know the full history, but the person's got an elevated free T4. And let's say that T3 is in the low end of the lab reference range, right? Well, that's still probably pretty low if it's within the lab reference range. Maybe, let's say it's all within more we'll call the optimal or functional range. Mm-hmm. But if free T4 is high and free T3 is in the low end of the reference range, and the patient's got insulin resistance and blood sugar regulation issues and maybe elevated lipids, and she's got anxiousness and she's got thyroiditis, meaning she's got inflammation, something's not quite right. That's where I would want to look at the free T3 to free T4 ratio. So free T3 to free T4 ratio. So what that's going to tell us is how good a job is my body doing converting free T4 to free T3. And the scientific papers, when they're looking at this ratio, and they look at this quite a bit to look at this, the tissue level of thyroid hormone, they're looking at a ratio of 0.31 to 0.34 as where that value should be. Okay, so don't go to you can't just go to your labs and do the calculation, because you have to be in the same units, right? But if you get them in the same units and you do the calculation, you'll be able to see what yours is. But in that person's, I would imagine that their free T3 to free T4 ratio is low, indicating more of a tissue hypothyroid state. I'd still take a look at their T3 to reverse T3 and their free T3 to reverse T3 ratios. And then I would start looking for, does this person have elevated inflammatory markers? I already know they got thyroiditis if they've got the nodules. So I'm already considering the fact that somebody's got an immune issue. They're getting some inflammation to their thyroid gland. I should see indications of thyroiditis. This is a person, even though their labs are still hanging on and they're making enough thyroid hormone, they're not converting it well. And if they're not converting it well, that's going to start to create that tissue effect, and they're going to start to have some of those hypothyroid signs and symptoms. But then we've got to start looking for why. So is this a person that's healthy? I mean, I guarantee you, if somebody just looked at that and say, hey, there is nothing wrong with you, these values are all good, you don't have a thyroid problem, she doesn't maybe have a diagnosable glandular hypothyroid or hyperthyroid condition at this point, but she's got damage occurring at the thyroid gland. And episodically, she may have increased dumping of thyroid hormone out into the system, and episodically lack of thyroid hormone dumping in the system. We may just be catching her in the phase where there's plenty of thyroid hormone dumping out into the system due to some thyroiditis of the gland. So that's where we have to take a look at the rest of what's going on. So when the person says, why might it be elevated? I would say there's a conversion issue, and do that conversion, free T3 to free T4, look at the T3 to reverse T3, look at the free T3 to reverse T3. If you get kind of multiple of those factors showing that there's reduced conversion, look at the rest of the panel for inflammation, then look at the rest of the panel for tissue indicators or lab indicators of tissue hypothyroidism, insulin resistance. I think they mentioned that in here. Look at the lipids to see if they're dysregulated, right? So that would be my most likely answer because the patient's not on medication.
So that is interesting because our next question says, how important is reverse T3? Because my endocrinologist says it's irrelevant. So I think you just answered that in general. And our book talks about the state that most practitioners do think it's irrelevant because they just don't understand the mechanisms. And so please refer our book to your practitioners. We also have a lab panel. If you go to requestatest.com, there's the Thyroid Debacle lab panel. We don't make any money off of it at all. So please do your labs where you want to do your labs. However, that'll show you what's in the book about what Dr. Eric will order on his patients. And so you'll see that. So that's what I wanted to mention that today. But again, let's go back to reverse T3. In the next question, I think we can kind of build this in. It says, some doctors say reverse T3 is elevated. You need to be taking T3 because taking 3T lowers reverse T3 and reverse T3 blocks T3 from working. Okay, all issues that are propagated and need to be cleared up. So clear that up for us, Dr. Eric.
So I think in the endocrinology, allopathic endocrinology model, reverse T3 is not important for what they're trying to do.
For what they're trying to do.
Right? So for their model, they are trying to diagnose at what point does this person have enough damage to their thyroid hormone that we need to provide thyroid hormone replacement therapy. And reverse T3 does not play into that.
Correct.
Right? How do we know when the thyroid gland is not making enough thyroid hormone to support the physiology? Allopathic medicine has said it's come down to two numbers. One, a TSH, which is the kind of the screening test, and the other is the free T4 value. So why TSH? Why would they say that? Well, you've got the hypothalamus, and that is the kind of the big driver of how much T4 is in the system, because the hypothalamus does not really transport T3 into the hypothalamus. It's not transported into the hypothalamus. T4 is transported into the hypothalamus. The hypothalamus then converts the T4 into T3. And based on how much T4, free T4 is in the bloodstream, that determines how much T4 is converted to T3 in the hypothalamus. And then if there's lots of T3 in the hypothalamus, then T3 binds to receptors in the hypothalamus. And then TRH, thyrotrophin releasing hormone, which is the hormone that then goes to the pituitary gland and says, hey, make TSH, that's reduced. Because if there's enough free T4 to convert into T3 at the hypothalamus is telling the pituitary gland, hey guys, I'm good. I got plenty of hormone. You don't need to make any more. And so then we would assume that that's enough for all the rest of the tissues. And when we're in a homeostatic state, that may be true. But the receptors at the hypothalamus are about 10 times more sensitive to thyroid hormone than a lot of the peripheral tissues. So when in an allostatic state or a stress state, that can totally not be sufficient for the peripheral tissues. You can quickly stabilize the hypothalamus despite there being insufficient levels in the body proper. Now, why is that important? Well, if you're in danger mode and you're being chased by the proverbial tiger, what do you need to be working primarily? You need your brain to work, right? And so that's why the hypothalamus kind of has top priority in getting thyroid hormone. It's so sensitive and receptive to it. So for an MD to find out, do I have enough T4 in the system if I don't have enough T4 in the system, then I need to provide T4 to bring TSH into range. There was a point in the past where they tried to use reverse T3. They even tried to use T3 early on, and they didn't really understand how to use it or what it meant. And so they just kind of scrapped those things. Kelly and I have both read through the guidelines, and there's a lot of things they say like, hey, elevated cholesterol is a really good sign of tissue hypothyroidism, but we're not going to make it a thing to check, right? But right in the guidelines, they talk about how you could use that as an indicator of tissue status, but we're not going to check it, right? So some of those things are weird. So from an endocrinologist standpoint, their only real job here is to determine, do I need to provide T4 and how much? And the goal is to provide enough T4 to maintain TSH within whatever set point range that they're trying to do that for. And you might say, well, doesn't reverse T3 show that maybe I'm over medicated? Not in that world. That is not an important factor in that world. So no, they're not going to take a look at that. It's just the way it goes. So for an endocrinologist, they're going to say it's not important, it's irrelevant because it doesn't relate to what they do, right? If I'm a mechanic and I fix engines and you're going to talk to me about plowing fields, that's not relevant to what I do. I'm not paying any attention to it. So yeah, that's not important. Plowing fields, not important. I fix engines. And I agree, it's probably not important. Same for that endocrinologist. Now, the other part of that is, but is it important? Well, I think it's important to people who use that reverse T3 as an indicator of what might be happening in the rest of the body, away from that hypothalamus. And that's what we do in functional medicine. The problem is there is this thinking in functional medicine that reverse T3 blocks T3 function at the nucleus and the mitochondria. And there really isn't any scientific evidence to show that that really happens. And so you keep hearing that over and over and over, and you'll hear people say, well, if you're taking T4 and and that T4 is converting into reverse T3, that reverse T3 is going to block any T3 from working, therefore you can't take T4. Well, reverse T3 doesn't really bind to the receptors, so it doesn't block it. What actually blocks, if you want to say blocking for anything, it would be the enzyme deiodinase 3 that deactivates T4 to reverse T3 is what blocks the action. Or you could say that deiodinase 3 blocks T3 from binding because deiodinase 3 deactivates both T4 to reverse T3 and T3 to one of a couple forms of T2. So deiodinase 3 is the big blocker, right? And so why would somebody think that taking the T3 is better if their thought process is reverse T3 is blocking the receptor? I understand why they might say that, but there's a problem with the logic. One of those is they're not thinking that the enzyme that was deactivating T4 to reverse T3 is still present, and it's still going to be in a deactivating mode, and it's still going to deactivate thyroid hormone, which is T3. So I've had people say, but I feel better, or I felt better when I started on T3. You did, but why are you taking more than 5 micrograms per day? Well, because I felt good for a while and then I plateaued and I needed a stronger dose. Okay, right? This is the same story. So you took it for a while, the body's like, oh man, that's more, that's great. Oh, that's right, we don't want that. And you deactivate it. And somebody would say, yeah, but your reverse T3 is going down. Right, but reverse T3 is going to go down because there's less T4 being made by the thyroid gland. There's less T4 coming into the system. And T3 can't convert to reverse T3. So if you don't have the starting piece, T4, it's absolutely going to go down. You're feeling better because you're flooding the system with T3, but you're plateauing because at a point in time, the body's going, we don't want faster metabolism. We want slower metabolism.
Right.
So I don't think we should be looking at reverse T3 as the thing to say, hey, because that's higher, I need to switch you to a different form of medication. When you see an elevated reverse T3, it might tell you, hey, I am taking a bit more thyroid hormone than I need, especially when you look at those ratios. And we want to take into context the signs, the symptoms, the other signs and symptoms as well. If you see an elevated reverse T3, it should tell you that your physiology is in more of that cell stress mode, or you're over medicated. Those are the two things it should tell you. I got some type of inflammatory mechanism going on that my body doesn't want to convert it, or I'm taking way more thyroid medication than I probably need. And then the doctor's job is to, in my opinion, I don't prescribe, but in the opinion is give that person the least amount of thyroid hormone that we can, but still keep them functional, and get busy trying to figure out what's causing that chronic immune inflammatory cell danger physiology. That's my answer.
Right.
So what's your thought?
I mean, when you say it as well as you do, and you have, the cherry on top, there's really, not a whole lot that I can add. And so, every time we do these webinars too, I end up learning all kinds of things. I've read the book several times, and I think that it is like everything Dr. Eric's saying, it's in there so you can go back and you can digest it. This is all really high level. If you haven't noticed, you have brilliant medical doctors who have that simplistic model, and, they're doing their best. And then, Dr. Eric comes in and gives us this whole new perspective. And even for someone as myself who's had medical training, it's a lot to digest. But again, like, read the book, review it. I think that you'll find that everything that we wrote in there is very digestible, and it'll make, more sense. It's what I would just say is, like, to second the notion that this is very complex, and there's not a whole lot of practitioners out there who understand the complexity of it. So I am, we're grateful that we have practitioners like Dr. Eric, and we will be training practitioners in this model as well. So I should mention that. So stay tuned for a practitioner course and a layperson's course for the thyroid debacle. We call it the strategic thyroid solution, because we're looking at correcting, as we've talked about, every one of these questions in the context of correcting the cell stress. And let me tell you, folks, it's not just one thing, right, Dr. Eric? It's not just one toxin or one heavy metal or one Lyme spirochete, or I mean, that's my soapbox, is that, be careful when you go to a practitioner who specializes in heavy metals or specializes in Lyme or specializes in, don't let them, miss the things that you can do that are very foundational. And that's how we started this talk. So,
but I think that's a good point to kind of build on too, because sometimes people are like, I get this call from people sometimes like, hey, who do you know who is a thyroid specialist in my area? I'm like, what you want is a really good generalist, in my opinion, who understands the thyroid physiology. Because what we see sometimes, and no offense to my peers or our peers, is that there's people who just are like, hey, I'm a thyroid specialist, and they just manipulate different types of thyroid medication, trying to find that magical mix or dose. And if that's all the person wants, that's great, right? Keep tinkering, and you got somebody who's willing to tinker with T4, T3, and keep kind of finagling things around. But that's not really what we're talking about in the thyroid debacle. It's not really what we should be doing, in my opinion, in functional medicine. Functional medicine is about saying, why is the body responding and adapting like this? And can we start identify and address what that is, and start reduce or eliminate those things, and support the recovery back to a more homeostatic regulatory state? If we can do that, then we can see tissues and systems recover. We can see diseases start to recover. We can see the person needing less and less medication in time. And that's what functional medicine is all about. How to raise the overall state of health, which doesn't happen very often. Now, depending on who you go to, because somebody might listen to what we just talked about and say, well, so is somebody who prescribes T4 only wrong? Is somebody who prescribes T3 only wrong? Is somebody who prescribes T4 and T3 wrong? No, there isn't a right and wrong. It depends on each individual situation. There's not right, there's not wrong, there's just consequences, right? So if you take T4 only and you don't address the root issues, you still may not feel good. But the same is true for the other two forms of medication. If you take T4, T3 combo, you'll probably have your honeymoon phase, but you're still gonna, if you don't address the root issues, you'll be busy playing whack-a-mole with lab values, but you're still in time probably not going to feel well. And so Kelly and I are both in agreement. It doesn't matter if you take T3 and you feel awesome, your signs and symptoms are good and you feel great. That's probably the right medication and the right dose for you. That's what you should probably be doing.
Right.
But if you don't feel well, then don't put all your, don't be like stuck to a treatment protocol, because that's like the thing. I have to be on T3 because that's what this person said.
Or I have to be on a glandular because a glandular is natural and the glandular is the only, don't get stuck. Right?
I just had somebody came off a glandular and, she's like, I feel way better on the T4 only. I'm like, right. Because the glandular provided more T3 than she needed. That was that between that and a T4, it was suppressing her TSH. Now her thyroid gland's not doing squata, right? And she was still not addressing the root cause. So she went through that same thing. T4 only didn't work, switched to a glandular, felt better, started plateauing. Then her doctor started giving her stronger doses. And then I am really hypothyroid. And my doctor says I can't because my TSH is so low. No, your TSH is so low because your blood is flooded, both T4 and T3, right? And so it's crazy. It's crazy. Anyway, we've got time for one more. So let's get one more in.
All right, let me read it since you're on a roll.
All right, you got it.
I started T4 medication. I felt better initially and then plateaued, just what we were talking about. My doctor increased and decreased the dose, but I still did not feel well. Then a new doctor switched me to T4 and T3 medication. Initially, I felt really good. Then I plateaued. The doctor now has me on, X amount, and I still have thyroid symptoms. Why hypothyroid symptoms? Why is the medication not working? Rewind the webinar just a couple of minutes ago. This is it. This is why this book is not just for people suffering with hypothyroidism. This book can help pretty much, like, if you're healthy. I mean, really, I got my kids doing the strategic thyroid solution. Like, hey, we can eat better. We can manage our stress better. We can learn how we're breathing through our mouth. I mean, my 15-year-old son is like, I'm like, Jack, we need to address that because you're 15 now, but if you keep continuing mouth breathing for X amount of years, I mean, again, all these little things, you guys, all these little things. And so that question, take it away, Dr. Eric. Go right back to what you were saying.
Yeah. So Kelly didn't give you the numbers, but so of what somebody put in there, right?
Go ahead.
But I listen. This person is taking the same. They're taking essentially what their doctor has them taking the same amount of T4 that the body makes every day, and the same amount of T3 that the body makes every day, right? So that's essentially what they're taking. They're taking a body's
physiological.
So they're taking over 30 micrograms of T3. So 5 from the thyroid gland, 25 micrograms from the peripheral tissues. And the person's wondering why they still have hypothyroid symptoms. Well, I'll give you a great answer. You've got so much thyroid hormone in the system that you're suppressing the gland. There's no way the gland's going to do anything because it doesn't need to. There's so much thyroid hormone in the system. And if you have that much thyroid hormone in the system and you're suppressing TSH and your body's saying, wow, we're flooded with thyroid hormone, guess what's going to happen to at the cell level? The cells are going to be like, they're not going to get conversion and there's going to be reduced transport across it because the system's flooded. So this is the trap. This is the trap that people get in many times. And then they'll come to me and say, hey, I got to do something. And the tough part, this is almost like somebody who's put on an SSRI or one of those medications, right? They've been on it for a long period of time and they want to try and come it off, and it's miserable because because they've lost the amount of receptors,
Yes.
and the neurons have lost the ability to produce it, right? So now they have a hard time making it. And even if you do make some, they don't have many receptors there to take it. And so they feel awful coming off of it. And what I've seen with people as when they're in this situation, that they're like, how do I fix it? Well, you can't have a TSH of 0.0001 and expect that your thyroid gland or their tissues are going to convert things very well. So we start helping them work with their docs to start weaning it down while we start fixing the stuff, but they don't feel well. I've got a patient on over 80 who's I just started working with, who's taken about 80 micrograms of T3 per day. And, she felt great when she was switched to T3 only, and then plateaued. And now she's on 80 micrograms per day and saying, hey, I feel awful. And I don't know what to do. And I'm like, we got to make some changes here. You never address the root issue, but she was seeing somebody they're a thyroid specialist, and this is what they do as an integrated physician, is put people on high dose T3. And I'm like, yeah, but you never address the root cause issues. Your thyroid gland is not going to be doing anything. And even though we talk about T4 being a non-active hormone, it's really not a non-active hormone, but it's a less active hormone. T4 still has function and action at the cell level, but its receptors are on the outside of the cells, not on the insides of the cells. So there's still actions for it. So I think this is a tough part. This person is saying, why is the medication not working anymore? She's got more resistance going on based on underlying issues still there, and creating this kind of cellular resistance with flooding the system. Thoughts?
Right. Spot on. So I think maybe we could give an opportunity to the people who are here live. If they have any questions, we'll just leave the chat open here for a minute. If that's okay with you, Dr. Eric, we have a couple more minutes. So if anybody has,
So let's do this. We want to, with the couple minutes we have left, if we see a question come up, we'll get it answered. We appreciate everybody who comes on and asks questions. I think that's awesome. But we're going to do a few more of these. But look, if you haven't gotten the book, please go out and get a copy of the book, because we talk about a lot of the stuff in the book, as to kind of trying to get into the physiology a little bit, but not make it too heavy, too complex. And then that part 3 of the book, we really do talk about what are the things that somebody can do on their own, right, without a lot of additional help. I did have somebody who read the book and said, hey, that was great. I was looking though for what supplements should I be taking? I'm like, go back and read the book again, because you missed part of the book, in that we don't want to give you just, if you have this, take that. If you have this, take that. That's not really functional medicine. And there's a lot of books that'll do that for you. What we want you to do is be able to utilize lifestyle changes and dietary changes to try and help get yourself back to an optimal state. If you ignore all these foundational things that we talk about, dietary fitness, physical fitness, sleep fitness, emotional fitness, I will tell you this: when I have someone, and I kind of, after 27 years, I kind of figured out who these people are, who have a lot of, it took me a little bit. I'm not the sharpest tool in the shed, right? But there are people, and you start to know who they are when you're talking to them. These are people that have a lot of emotional baggage, a lot of emotional trauma. Some of them know it and are trying to address it. Some of them know it and don't want to address it and think they can just move on past it and it's not going to have an impact. And then there's people that don't really even realize that might be holding them back. But that is one piece with some of the patients that have had the hardest time getting better, getting them some of that help. We've talked to Madeline Lowry on the Thyroid Answers podcast. I think we mentioned the MAP method in the book. I could tell you she's done some great job with a number of my clients that had a lot of neuro-emotional issues, OCD issues, anxiety. And
Yep.
Man, it makes a big difference.
When it's appropriate, absolutely. And I would point people to the ACEs questionnaire, the Adverse Childhood Experience. If you have an inkling that perhaps emotions could be at a root cause of your health problems, not the cause, but again, something that could be holding you back, I would look to doing that questionnaire. It really is powerful in directing you to perhaps something more than just physiological help. And yep, we like EMDR, we like the MAP method. There's a lot of things that we can do in taking control of our health, right? Don't put your health in someone else's hands, take control of it. And again, I think that the thyroid debacle is a gift to people who want to take their health in their hands and be more of their advocate, because I see, that's a big problem that we have.
I had one of my clients in the other day, and he said, "Hey, I don't have a thyroid problem." No, he probably does, because I know him. But he said, "Could this book help me or my family?" I'm like, absolutely.
Yes.
Because it's going to help you understand how kind of the allopathic model works.
Yes.
And it's going to help you understand the cellular physiology component, and whether you have a thyroid problem or any problem or no problem. If you understand the cellular danger, allostatic versus homeostatic regulation, it helps you understand a lot of the problems that we develop. And then that part 3 of the book is all about what are the things you can do without hiring a physician to start fixing, addressing your physiology, how improving it, raise what we call your level of fitness in each of the categories that we talk about that are foundational pillars to health. So we think it's a good book for everybody. So I know we've got to finish up.
Okay.
We appreciate everybody who's been on the Q&A today. Stay tuned. I think we've got a couple more of these scheduled over the next couple months. If you do have questions and they didn't get answered today, you can always send me at my website, rejuvegencenter.com, or wherever you see some of these videos maybe in the future. You're probably on our email list. You can send us an email with the questions that you have, and we'll be sure to try and get them answered. So Kelly, thanks for being on the Q&A. Everybody who is here, thank you for being on the Q&A. And we'll talk to you guys all probably in a month.
All right. See ya.